to introduce Dr. Shtridler.
Hey everyone, I'm Alina. I'm one of the EMI interns. I'm going to talk today about ischemic strokes. A lot of this was already covered in Subham's talk, but I'm hoping this will be a good adjunct and kind of going back to the basics of ischemic stroke management. How do I?
Just click on that.
Okay, so you're in CCT and the red phone rings, and this is what you hear on the other line. You have a 68-year-old female with major vessel occlusion. She has a facial droop and right-sided deficits, and they're 5 minutes out. That is all the information you get. So you try to be proactive, you call a stroke code. And then while they're getting there, you're trying to think to yourself, what do I do after? So that's kind of what I wanted to talk about. I wanted to go through the initial workup of a stroke patient, give you a brief overview of like the large vessel strokes and the common presentations, talk a bit about the indications and contraindications of TPA administration, as well as the endovascular therapy, and then the secondary stroke prevention. So first things first, you get this patient, what do? Well, you go back to your basics, ABCs, right? Then you want to ascertain the time the patient was last known well, because that's going to determine whether they might be a candidate for TPA or endovascular therapy. Next thing you want to do is you want to try as quickly as possible to rule out any stroke mimics. The quickest of these is probably to rule out hypoglycemia. This is also why we draw a bunch of our labs to rule out hyponatremia, to rule out other metabolic dysfunctions. And other things you want to think about are like maybe the patient is post-ictal and actually has Todd's paralysis, maybe they just syncopized, and maybe they have like some kind of hemorrhage. So next thing you want to do is you want to pull out your MD calc and go through the NIH stroke scale to determine the severity. And then lastly, you want to get a non-contrast CT scan to make sure that they're not having any kind of hemorrhage or any kind of neoplasm that is causing their symptoms. So going through the timeline of how quickly you want to make these things happen, immediately when the patient gets there, you want to try to call a stroke code. You want to try to get the patient into CAT scan within 20 minutes of them arriving at your ED. And you want to try to administer IV thrombolytics within 60 minutes if they're indicated. Some imaging considerations. A non-contrast CT is actually the only study that is necessary prior to administration of thrombolytics. I know a lot of times we also do CTAs or MRAs or like diffusion-weighted MRIs. Those are not required before you can give thrombolytics. CTAs or MRAs can help detect the exact location of the large vessel occlusions and can help to plan for endovascular therapies. But they shouldn't delay any thrombolytic administration. And actually, I was reading that you can give thrombolytics before doing the CTA. And then the perfusion CT and diffusion-weighted MRIs can be used to identify the size of the penumbra and can help guide the possible thrombectomy up to 24 hours after symptom onset. So quickly to just give a brief review of the major blood supply to the brain, you have the ACA that covers most of the medial side of the brain. You have MCA that covers probably the majority of the brain, and then you have the PCA territory that covers the occipital lobe and the cerebellum. And then in the motor and sensory cortex, this is the distribution of the ACA covering the mostly lower extremities, the MCA covering the upper extremities and the face, and then the PCA covering visual fields. So with an anterior cerebral artery infarction, the main thing you're going to see is deficits in lower extremities. With a left-sided lesion, you can also sometimes see akinetic mutism or non-fluent aphasia. And with right-sided deficits, you can often see confusion and motor neglect. Middle cerebral artery infarction, the most common, so this is the distribution. You can see that it covers a pretty large area of the brain, probably the majority of the brain. And these are the very typical things that we look for in a stroke. You'll have facial droop, you'll have arm weakness, and then you'll have an aphasia or speech deficits. You can also see hemineglect, you can see constructional apraxia, and you can see homonymous hemianopsia. With posterior cerebral artery infarction, you see that it covers mostly the occipital lobe. So you can get ataxia, you can get nystagmus, you can get alexia without agraphia, so you can write but you can't read. You can have phase blindness, and you can have a variety of visual dysfunctions such as visual illusions, hallucinations, and I wanted to point this out because I think a lot of the times when we think of, when we look for vision changes, we look for an inability to see, but this is actually the opposite. You can have the opposite. And then I wanted to talk about basilar artery occlusion. So you see that it covers, it goes mostly to the cerebellum, and it also branches off into the posterior cerebral artery. So you'll have the same findings for the posterior cerebral artery, plus you'll have nausea, vomiting. You can have cranial nerve 7 deficits because of its location because of the involvement of the cranial nerve 7 nuclei. And you can have unilateral limb weakness. And also you can get locked-in syndrome where you can't move, can't talk, but you can only blink. And this is due to involvement of the pyramidal tract lesions in the pons. So you get a CT scan, and this is what you see. So kind of like what Suvam had already pointed out earlier, here we actually see a dense MCA sign. We see hypodensities on the left side, and we see loss of differentiation of the great white matter and loss of kind of the structure of the brain. Okay, so then you're starting to decide, well, what do I do with this patient next? Can I give them TPA? So the absolute contraindications to TPA are that the patient had an intracranial hemorrhage on CAT scan or clinical presentation of subarachnoid hemorrhage. You can't give TPA if the patient had any neurosurgery, had trauma or stroke within the last 3 months. If they have uncontrolled hypertension with systolic blood pressure over 185 or diastolic blood pressure of over 110, they have any history of intracranial hemorrhage, if they have any known intracranial AV malformations, neoplasms, or aneurysms, if they have any active bleeding, or if they have suspected or confirmed endocarditis, or bleeding diatheses, or hypoglycemia below 50. And all of this is available in MD Calc, so you don't actually have to remember any of this. Just know that you can access it. So one of the contraindications is uncontrolled hypertension, but a lot of our patients come in with blood pressures over 185 systolic and over 110 diastolic. Does that mean that they can't get TPA? Not really. So one thing you can do is you can try to control their blood pressure before giving TPA if you think that the patient is otherwise a candidate. So you can try giving them labetalol 10 to 20 milligrams IV over 1 to 2 minutes, and you can repeat that dose. Another agent is nicardipine, which you can give as a drip, or clofidipine, which I haven't seen used as often. But you can try that, and if you can control the blood pressure and the patient is otherwise a candidate for TPA, you can give it. You want to try to give TPA within the first 4.5 hours after symptom onset. And the dose you would give it at is 0.9 milligrams per kilogram IV. With 10%, if you're going to give it, you have to give 10% of the dose as a bolus over the first minute, and then the rest infused over 60 minutes. Things to look for after you give TPA, you want to make sure to really keep an eye on the patient's blood pressure. So within the first 2 hours, you're going to check their blood pressure every 15 minutes. Within hours 3 through 8, you're going to check it every 30 minutes. And within 9 to 24 hours, you're going to check it every hour. Again, if the patient is hypertensive, you're going to use the same agents to control the blood pressure, labetalol, nicardipine, or clofidipine. If the blood pressure is still not controlled at that point, you can consider sodium nitroprusside infusion. Other things to look for are signs of bleeding. So if you're suspecting any kind of intracranial hemorrhage or bleeding, get a CT head, get labs, get a typing screen, make sure that they don't need a transfusion. Another common side effect is orolingual angioedema. It happens in up to 17% of the cases. And those, I've read that those people that are taking ACE inhibitors are actually at greater risk. So you want to stop the drug and go back to your ABCs. And then because of this more frequent monitoring, these patients should either go to a stroke unit or an ICU level care for monitoring. Another thing is, another potential option is endovascular therapy indications. So those are really for patients, those can be used for patients up to 24 hours after the onset of symptoms. And it's really only indicated for patients who have an occlusion of the ICA or proximal MCA in one territory. For patients that like at baseline have a ranking score of 0 to 1, which means that they either have no disability at baseline or no significant disability and can still perform all of their ADLs. And you want to have a stroke severity scale of greater than 6 and an aspect score of greater than 6. Suvo had touched on it briefly, but here I have actually a photo of like the aspects scale, and it's helpful because you don't really need to remember what any of these things are called. You can just look at the CT and take a look at like what the involvement is and just click yes or no. And you want to, if you're going to do endovascular therapy, you can do it up to 24 hours, but you really ideally want to try to get it within the first 6 hours, within 6 hours of symptom onset. And then as for secondary prevention, if you're not giving TPA, you can give aspirin within 24 to 48 hours after the stroke onset. If you're giving TPA, do not give aspirin. The other thing to start these patients on is make sure they're on a statin, make sure that you have good glycemic control, and to counsel them on lifestyle modifications. So takeaway points are: remember your ABCs, your labs, your CT head, and asking the time last known well. Non-contrast CT head is the only study that is actually necessary before giving thrombolytics. ACA strokes will give you lower extremity deficits. MCA strokes will give you upper extremity deficits, facial droop, and speech difficulties. PCA strokes will give you ataxia, nystagmus, ability to write but not read, and vision changes. You want to give TPA within symptom onset of less than 4.5 hours. Endovascular therapy can prolong that time to up to 24 hours, and you want to make sure to control blood pressure and monitor for bleeding or angioedema after you give TPA. Questions? So these are my references, and I want to thank the members of the clinical pearls team that helped me with this presentation, particularly Dr. Tan and Dr. Delgado.
Elena.
Yeah.
What's the difference between giving TPA within 3 hours versus 4.5?
I don't know the exact studies on that, but I don't know off the top of my head. But I will look it up and I will send out an email later.
After 3, between 3 and 4.5, you have to be a little more careful. There is an increased incidence of bleeding. So if there was some relative contraindication and it goes up to 4.5, you might not want to do it. I'm going to stop at 3. If there are no contraindications, I think then you would probably go up to 4.5. So you can look it up.
Will do. Thank you so much.
Yeah. I was just going to comment. I agree with Dr. Gernsheimer's assessment of that. I think probably in conjunction with a neurologist, I think emergency medicine physicians should really stick to the 3-hour mark. The studies aren't as well performed, and there is a higher risk of mortality. Generally, no one who's older and anyone who has diabetes or previous strokes, you're going to even think about giving TPA over 3 hours. But I shared my thoughts about, use of TPA before. But I think as an EM physician practicing yourself and just giving TPA, you should probably stick to the 3-hour mark.